imaging session, which is about OCT. When before, I did my thesis with Professor Gupta, and it was on laser photocoagulation. So he told me that you have to chase these patients to their grave because many of the diabetics die. You should convince them to enucleate the eyes so that we can see what was happening within the layers of the retina. So starting from my thesis, reaching to a level where you can actually see the cones and the rods, the journey has been truly, truly amazing. And all thanks to the in vivo or the optical biopsy that OCT is giving us. So I will skip the time domain and all because this is what most of us would have by now, is the spectral domain OCT. This gives a very high definition, high resolution scan. We have a better SLO pictures. You can actually see the pathology, put your lesion. This is the conventional two-dimensional scan. We can have three-dimensional scan. We can take slicing of each layers. This is the internal limiting membrane. This is the RPE, and study what is happening in these individual layers. Eye is like an onion. So if you make the onion rings, you slice it like this. So if you slice it like this, you will see individual layers of the retina like this. This is called en-fast OCT, and you have the facility to superimpose it on your fundus photograph and sometimes even on fluorescein angiography to correlate what is happening on OCT with what we are seeing clinically. This is the international nomenclature from the OCT meeting, which is something which we all should be using to be on the same level. This is the posterior cortical vitreous out here with pre-retinal space, nerve fiber layer. Then you do have individual layers including the ganglion cell, inner plexiform, nuclear outer plexiform. But by and large, you don't get much information from individual layers if you want to study. What is important to the retina surgeons is something like this. This is the external limiting membrane, which produces a single hyperreflective line. The area which is outer to the external limiting membrane is called outer retinal segment. And whether our patients are going to get their vision back or not would depend on the restoration of this outer segment. And why is it so important? It is important because all the structures, photoreceptors and all are located within this layer. So now let's concentrate on this. We have the external limiting membrane, then we have the myeloid zone. This is the hyperreflective zone, which is between the external limiting membrane and this hyperreflective layer, which is called ellipsoid zone. This used to be called ISOS. It is still called ISOS by many, but the latest terminology is to use it as myeloid zone. Then we have the outer hyperreflective space, which is the outer segment of the photoreceptors. And this is generally elevated here because if we look at the anatomy, the cones are elongated in the fovea. So this always seems elevated. This is not a fluid and should not be mistaken for the fluid. And this is what is the outer segment. Then we come to this hyperreflective layer here, which is interdigitation zone, followed by the RPE Brooks membrane. We also see the layers in the choroid. Now this is the layer of the choriocapillaris. Then is the smaller vessels, which are Sackler's layer, and the outer choroid, which is the Heller's layer. And if we are lucky, we may see the junction between the choroid and the sclera. EDI sir has already shown, so I will not go much into it, but this shows all the three layers of choriocapillary. This is the Sackler's layer and this is the Haller's layer. What have been the shortcomings of spectral domain that we want to move this? It needed a better resolution because we want to see the individual retinal layers. Doing EDI with spectral domain is fine, but if we want to know more details of choroid, we need a better technology. and we cannot have choroidal three-dimensional maps with the conventional spectral domain what we have. So we have a newer technology called swept source OCT. So what exactly is swept source? It is ultra high speed swept source or the Fourier domain, which actually takes much more scans compared to the swept source, so you can see deeper in a better way. I will not go into technicalities, I would just show the images. These are the images of the usual ST OCT, and this is the swept source OCT. Now let's look at the optic nerve head, let's look at the depth. Starting with the corneoscleral junction, you can see the lesions in the choroid much more deeper and more precise with this swept source OCT compared to the spectral domain OCT. One problem in spectral domain OCT, especially when you are studying choroid, you have to manually put the markers because it does not define the outer limit of the choroid or the beginning of the sclera. So you have to put the marker, and when we say choroid is 406, it will depend where I thought the junction was, because I am the one who decides this is the choroid scleral junction, but somebody else may think it otherwise. In swept source, we do not have this problem. You can see here is the junction, which is very well defined, which is well demarcated, and you can study the choroid as well as you can study the retina. Another good thing which swept source is teaching us is more and more about this precortical pocket. This is the pocket which is a kind of a reservoir. So sometimes you have so much mediators of inflammation collecting within this pocket that if your intravitreal injection is reaching somewhere here, and you are giving it here and is not accessible to this pocket, you will not have a good response. Or if you have an inflammation and your mediators of inflammation are accumulating in this, you may keep on giving steroids or something, it may not help unless you mechanically remove it, remove distraction, release those inflammatory mediators. That is why vitrectomy is picking up more and more as a therapeutic measure compared to what we were doing it. This is what the en-face OCT of the choroid looks like, showing us the choriocapillaries. This is a patient with the outer retinal tubulations. En-face has a distinct advantage that you put it on the fundus picture and you see what you are seeing is corresponding to what you are doing. Now let's see about ARMD. We heard about ARMD from Dr. Raman, that anti-VEGF treatment produces good short-term results. Sir showed us beautiful autofluorescence where he said that even if you keep on injecting, RPE does get atrophied over a period of time, which is seen as a dark spot. So you may be injecting, patient not improving, keep on injecting 40 injections, 50 injections without bothering to see what is happening to the layers of the RPE and choroid. A very interesting study has shown that choroidal thickness is decreased in patients with new vascular AMD and decreases further with anti-VEGF therapy. So if you are monitoring these patients on enhanced depth OCT and you realize that choroid is undergoing atrophy, maybe it is a time to talk to that old man that okay, I am giving you injection, I might be reducing your fluid, but probably you may not gain much, because it is not only that person, it's 2-3 people coming with him month after month, receiving injections, subjecting the old people to a lot of hassles, but we need to know whether it is worth it or not. This is an example of a new vascular AMD at presentation. Now let's look at the choroid. The choroid is showing hyperpermeability and there is increased thickness of the hallux layer, which is the bigger layer. We are not seeing any Sattler's layer, not much of it here. So he receives multiple injections of Avastin and see what is happening to choroid. Choroid is decreasing in thickness but also becoming atrophy, and you see the choriocapillary layer is seen, but we straight away see hallux layer and we are not seeing any saccharous layer. So if choroid is not good, it's not going to give good blood supply to the retina. So we may be getting carried away with the reappearance of some pocket of fluid here and there and keep on injecting more and more without bothering to see what is happening outside to me. Last part of my talk after the swept source is adaptive optics. So adding adaptive optics to the OCT, what does it do? It increases lateral resolution, so it becomes so small that you can pick up even a small cell in the retina, which means rods and cones. This is how it looks like, the rods and cones. You can see individual cell, you can measure their density, you can't measure the function, but you can measure their density anatomically. So this is how a normal mosaic would look like. These bright dots are the cones, which are larger towards the periphery, and you see increased density towards the center, because we all know the cones are densest in the foveal center. And this is how you can choose the area. You also have the density color scales. If you want to see the density of the cones in a particular, you choose a cube of the area and you see how much cones are located there. If you focus it anteriorly, you can see the blood vessels, you can see the caliber here, the blood vessels, the AV ratio, and people are using it to monitor atherosclerosis and arteriosclerosis. And even for the cardiac patients, if you have adaptive optics, you can use the retinal vessels to monitor the overall health of the vessels. This is the patient I showed yesterday also. There is a patient with foveal scar which shows a total damage of cones. So be careful about shooting the laser, because we are killing the photoreceptors, and we now have in vivo histology showing us that we are losing. Same as the patient here to study the blood vessels. This is a patient showing through the CSC. And this shows the photoreceptors loss at the point of the leak, which means that CSC also, the long-standing fluid, might cause some damage to photoreceptors. This is a patient with myopic foveoschisis, again showing the loss of the photoreceptors. Or the macular hole. You can see here the macular hole, and it can be used to monitor to see whether it can be restored or not. This is the patient with CNV who has received treatment, shows the heel scar, but the photoreceptors you don't see on adaptive optics. This is the scar of the CNV with the overlying photoreceptors dead. This is a patient with Behçet's disease. This is during follow-up when adaptive optics was done. You can see the retinal vessels and the perivascular infiltration. It can be used for glaucoma as well. So to conclude, spectral domain OCT is very useful for studying the retinal pathologies, which are not very accurate for choroidal, but is not very accurate for choroidal pathologies though. Swept source OCT is very useful for choroidal pathologies. C-scans are providing more useful, and we have to understand and fast our C-scans, because our OCT angiograms are going to be C-scans. So we have to do a mental shift now from B to C, because future is with that. And adaptive optics provide better cellular resolution, but probably I would not say that adaptive optics has reached a stage where we need it in our clinical practice. Honestly, it feels good to look at the rods and the cones, but you can do it otherwise also by autofluorescence or by other imaging modalities. Thank you so much, and Raman, please join us here. And we would be happy to take any questions.